It's my great pleasure to welcome Dr. Dean Preddie, an interventional nephrologist from New York, to this conversation. He will talk about the placement of PD catheters. So, Dean, could you tell us a little bit about the topic you will cover at the RRI conference?
Thank you, Dr. Kotanko. It's wonderful to participate with you, and I'm very grateful for the opportunity to speak with the audience about PD catheter. We'll focus a little bit on PD catheter placement, and we'll talk quite a bit about the advantages and disadvantages of the different types of placement techniques. We'll look at some of the advantages of the percutaneous technique, which we employ, and why we think that's an advantageous way to approach getting a permanent PD catheter inserted for the patients. So we'll look at really everything to do with PD catheters themselves and why we choose to do things the way we do currently.
Yeah, so this sounds really interesting. I mean, given the situation that home therapy is really improving and increasing rapidly in this country. Now, a question that frequently comes up, who do you think should actually place the PD catheter? Is it the nephrologist? Is it a surgeon? Other groups? What's your take on that?
My take is that the one with the experienced hands really is the one that you want to utilize for your patients. The most important factor really is the specialist who spends a lot of time placing these catheters. When you look at the data, the type of approach really is equivalent when it comes to percutaneous versus laparoscopic techniques. We find that there's equivalence in leak rates, there's equivalence in infection rates, there's equivalence in function after 1 year. It's pretty much very similar. Where there is a difference is really the recovery time and how quickly a catheter can be used. So in our estimation, it's most important that you have a specialist who is committed and is experienced in placing these catheters and are going to be available for you should complications arise or if there's any problems that would come from having the catheter.
Yeah, I'm just wondering, I mean, there's so many different types of catheters available. Are there actually clinical factors that guide your choice of a specific catheter?
We find that the double cuff catheter that is not pre-curved, it's pretty straight, but it can be placed in any direction you like, tends to be the most effective catheter. I've tried, several different types of catheters, and I have found in my personal experience and it's borne out in some of the anecdotal reports in the literature that type of catheter tends to be the most successful. Weighted catheters aren't any better for patients. They still can get migration of the catheter into the right or left upper quadrant. So these catheters tend to have the best longevity and the best outcomes for us. So that's what we use most often.
Yeah, so thank you for sharing your take on this question. So I'm wondering, when you look back over the past, say, 5-10 years, what were in your mind the most important innovations with respect to PD catheters, be it the catheters themselves, but also with respect to placement techniques?
The catheter technology hasn't changed a lot in the last 5 years or so, so it's been pretty much the same. But what has changed is the way we do our percutaneous techniques has really evolved over time so that we are having much better outcomes than we did a decade ago. We were hampered by a lot of, post-procedure leaks, especially when patients use the catheters in the short term within 3 to 5 days post-placement. Now, because of the change in the way we do the catheters, the way we tunnel them, the way we get our cuff at the rectus muscle, we don't have leaking anymore. And so now we can place a catheter and give the green light for use within 3 to 5 days after placement. And sometimes we've had it started within 24 to 48 hours after placement. And we can have good success with it and not have leak or have problems with any changes at the rectus muscle layer. So the techniques have evolved and been fine-tuned and I think are much more successful.
Yeah. So I have to say, this is so good, so encouraging to hear that real progress has been made when it comes to the placement technique of catheters, progress that truly translates into better patient outcomes. I'm just wondering, at which GFR would you place a catheter, a PD catheter in patients?
We have as you know, the nephrology community has evolved over the last 10 plus years with start dates for dialysis. It used to be that as soon as the GFR dropped below 20, we were ready to pounce on the patient and put them on dialysis, get them worked up for transplant, so forth and so on. Nowadays, we usually let symptoms drive the discussion. In my estimation, just to be prepared for dialysis, we like to place the catheter 2 to 3 weeks before the patient is going to need to start, so they have time to get the catheter in, time to initiate the training, and be able to get the kind of dialysis started so that they're not waiting till they're in extremis to initiate dialysis. So generally with the GFR in the 12 to 15 range, we're starting this conversation in earnest, along with the nephrologist and the patient and their family, so that we can be proactive in getting the catheter placed so that they can be in the best position to start dialysis. Remember that with peritoneal dialysis, we tend to be able to preserve residual renal function a lot better than with hemodialysis. So starting a bit earlier doesn't necessarily compromise that last bit of renal function as much as it does with hemodialysis. So we can err on the side of being a little bit more aggressive and looking at 15 cc's per minute of GFR before we start to initiate getting the catheter placed.
Yeah. So now let's assume the catheter has been placed successfully. What in your mind, for the practicing nephrologist, for the healthcare provider, what are the 3 most important mistakes that are avoidable after PD catheter placement?
Right. So most common mistakes that are made is when we are not appraised of the timing that the nephrologist would like to start initiating the PD. If I know that a PD is going to be initiated within the first 24 to 48 hours, there are some differences in my techniques to make sure that I reduce the opportunity for leak in and around the catheter. We can do supine, low volume exchanges, but we can do full exchanges if we know ahead of time. We can make the adjustments appropriate in the procedure. So not knowing that we need to make those adjustments, which aren't always done, is a problem. The second really is, once again, using high volumes very early on when the patient is not ready for it. And then lastly, the care of the catheter is so important. I'm not sure all patients are educated at the very onset exactly how to use exquisite hand hygiene, having good sterile techniques so they can reduce the opportunity for peritonitis. So those kind of things, care of the catheter, how the catheter is to be used and when it's to be used, is very important. And lastly, I'd say follow-up is critical as well. We've had times where we placed the catheter and the PD nurse was on maternity leave and the team wasn't ready to help train the patient. And now you have a catheter in place for weeks to months that hasn't been flushed or cared for. And so function is usually compromised because of that. So post-operative care needs to be coordinated. The whole team should be aware of what's going on so that we can give the patient the best care possible.
Yeah. Thank you, Dean. I mean, these are really important points you're making, and it's just important information for everybody to take home after the conference. So really, thank you so much for speaking at the conference. We're all looking forward to it, and I'm really happy that you set time aside to speak at the conference, and I wish you all the best.
Thank you very much, Dr.